and jury in the trial of this issue shall be the truth, the whole truth, and nothing but the truth, so help you God?
Yes, I do.
You can look this way. Watch your steps. You can adjust this microphone and speak clearly into it.
All right, good afternoon.
Good afternoon, sir. Could you please introduce yourself to the jury?
Yes, Kenneth Burch, Pediatric Cardiologist
And where do you work, sir?
at Savannah Children's Heart Center in Savannah.
Are you a medical doctor, sir?
Yes,
You said you're a pediatric cardiologist.
that's correct.
And are you here today because you briefly treated Quentin Simon, the victim in this case?
Yes.
Now, let me ask you a little bit about your education, training, and experience. Can you tell us about your undergraduate education?
Undergraduate, I went to Augusta College in Augusta, Georgia.
And
For 4
did you go-
years.
I'm sorry to interrupt you. Did you
Just
go-
went 4 years, yeah.
4 years, okay. Did you go immediately to medical school?
No, didn't, had a year before I was accepted, and then I went to 4 years of medical school, then I did 3 years of pediatric residency, and then 3 years of pediatric cardiology fellowship.
Where did you go to medical school?
Medical College of Georgia,
And when did you graduate?
1982.
You mentioned that you did was it a pediatric residency or a cardiology residency?
Well, a residency was general pediatrics,
Okay.
so I did 3 years of that at the medical college there, and then was fortunate that they thought enough of me to go ahead and offer me a fellowship in pediatric cardiology there before I was halfway through my second year of residency. So I stayed and did 3 years there
Our last
in
witness,
fellowship.
I'm sorry. Our last witness, Dr. Puente, has explained to us what a medical residency is, but I don't think we've heard what a fellowship is after residency. Can you tell us what a fellowship is?
Well, in a residency, you sort of do a lot of different things, but when you do a fellowship, you're specifically focused on one particular subspecialty. In my case, it was pediatric cardiology.
Okay. Is it fair to say that in your residency you gain your specialty, but in your fellowship you get a subspecialty?
That's correct.
Okay. When did you finish your pediatric cardiology fellowship?
1988.
And have you been working as a pediatric cardiologist uninterrupted since then?
Yes, sir.
Tell us where you worked as a pediatric cardiologist.
Well, initially was employed, if you will, Memorial Medical Center, starting July 1988, and worked in the pediatric department there doing pediatric cardiology until 1995, and I went out in private practice April 1st, 1995, and formed Savannah Children's Heart Center. I've been there ever since.
Now, as a pediatric cardiologist, how do you get patients? Where are these patients coming
They're
from?
referred.
Referred by whom?
Typically, other general pediatricians.
And what causes a general pediatrician to refer a child to a pediatric cardiologist? What kind of things?
Well, there are various different reasons. One of the most common, particularly in a young child, is because they hear a noise or a murmur when they listen. We also see kids for passing out, chest pain, all kind of other complaints. But
Now, can you tell us about Quentin Simons being referred to you?
I believe that Dr. Prince heard a murmur, and I think it was a new finding from what I gathered. And so he was referred for us to evaluate.
And tell us about that evaluation.
Okay. Well, how much? What do you want to know? Everything, or just? I'm not.
Can you do like a 1 minute?
Yeah. So basically, when he came into the office, he had a EKG performed, which was normal. Then I went into the room, and he was there with his grandmother. And he looked fine. Respiratory rate was normal, heart rate normal. His weight was above the 75th percentile for his age. Looked like he was thriving. And so I listened to him and examined him. He had a soft little murmur, so then we went and did the echocardiogram where we actually look at the heart. And that's where we those two minor things. One was a patent frame of valley, and the other was a very small, what appeared to be a coronary organ fistula into the PA.
The first thing you said was you said it really fast.
Patent frame of valley.
What is that?
Well, a patent frame of valley is a normal structure actually that all babies have before they're born. Okay, it's open in such a manner so that the blood that's coming up from the placenta, because the mother's providing everything, is preferentially directed across that opening, if you will, that left side of the heart. So most of it gets pumped out into the body as opposed to going back into the lungs, which are full of fluid and the vessels are constricted. And after they're born, the pressure change in the heart, then it just sort of flaps shut, if you will. Very commonly, it doesn't necessarily meet like it's supposed to and take time to close up and go away. Typically, large patent frame valleys, about 80% of them close, small ones, 95%. A small patent frame valley is restrictive, doesn't have a lot of shunting going from, because the shunt direction changes after the pressure in the lungs goes down, so now the left side of the heart has a higher pressure than the right side. Okay, that's got the blood pressure, and your blood pressure in your lungs is like a third of that. But anyway, so the direction of the shunt changes, and the criteria for intervening or closing it, or whatever you want to say, has to do with how big it is.
You mean surgically?
No, you can close it with devices.
Okay.
But sometimes it's surgically, it just depends. But if it's small and restrictive, and the right side of the heart is normal, you leave them alone, because it's actually probably going to do more harm than good, like closing it, if you will. And his was very tight.
Before you want to go further, is that PDF or the PDF?
PF, for AFFO.
Okay, and I'm having for, yes, please.
Is that spelled P-A-T-E-N-T?
Patent.
New word F-O-R-A-A-M-E-N. The new word O-D-A-L.
That's correct.
We got it?
I can get PFO, you know.
So was any intervention indicated for?
No, not for that, no.
Would you consider this a minor issue?
I was considered, yeah, you're talking normal activities, no limitations on activities, typically shouldn't have any affect life expectancy. I like to say he was only 13 months old when I saw him, so there was still a good, high probability that it was going to close up anyway.
By around what age?
Usually, mostly close around 12, 15 months of age. I've had some that were a little older, 2, 3 years. Some that you're looking at thinking, well, these may be large enough for us to do something about. And we typically, if we do need to do something, if they're large enough, we typically don't address that until they're 3, 4, 5 years of age. So, he was
Is that because you're waiting for it to resolve?
waiting for it to resolve, as well as get the child older, so everything is easier to do, particularly if you're going to do it with a device.
You mentioned, I think, also coronary artery fistula. Can you tell us about that?
Yeah, that's a very, very rare type of finding in the sense where I think it's about 0.01, maybe 0.02%. You see congenital. This is a congenital one. There are coronary fistula that you may see in adults that are undergoing bypass surgery and other kind of things. These are talking about a congenital one. And basically when the heart forms I mean, basically it's a single tube actually when you first start, and then it involutes on itself and so forth. So a lot of the structures are very close to each other. And sometimes, most commonly, the left anterior descending coronary artery may not actually totally close up when from the pulmonary artery. So you may have a connection. It's called the fistula. And the size of the fistula dictates what you do, meaning that if it's a small coronary fistula, less than like 1 centimeter or much less than the size of the coronary artery, I'll put it that way, then we just watch those. And most of those will even close up and go away on their own. Now, when we talk about larger ones, moderate to large, those are a little different. Those many times will need to take care of. But typically you'll see signs and symptoms with that. So it's not just looking and saying, oh, this is a small one. You're looking at other things as well. If it's a significant shunt, which means it's a big one, okay, into the coronary, then the left part's going to be dilated, there's going to be increased flow to the lungs, the child's going to be short of breath, he's not going to eat well, he's not going to gain weight. You see what I'm saying?
Yeah.
And so forth, and obviously, and of course, one of the risks with it, if it's a large one, is that once they get up and start playing sports and so forth, that they have an issue with ischemia or lack of oxygen to the heart. So you will repair those. Small ones, you watch. Sometimes they don't go away. So typically, when they're 10, 11, 12 years of age, when they reach that age where they're going to be affected by peer pressure or parental pressure to continue to compete, whereas little, they get tired of stop. When you get a little older, they try to run that extra lap or whatever. That's when you can get in trouble. If you have any issues, so we'll exercise them and make sure everything is okay, put the size of it. But I mean, I've had kids with small coronary fistulas that play, competitive athletics, high school, college, and so forth. But we have an issue. His was tiny. Tiny. You almost don't even want to mention it, but it's there, so you have to. Does that make sense?
We called you in here just to cover all this.
Okay.
That's why were either of these findings that you described of any serious concern to you? And you said this is a pediatric cardiologist with 30-some years experience.
That's correct. I've only had one coronary fistula that we've ever had to repair, and that was back in the 90s. And the rest of them.
Only one that I've ever had to repair.
And the patient did what?
How many kids have you seen with?
It's not very common. I don't know, 20, maybe 15 over the years. I don't, keep that number because most of the time it's almost an incidental finding because they're so small that you don't want to make a major issue out of it because then it may interfere with the child's normal activities and so forth. Everybody's going to be worried something may happen.
How many times did Quinn come to see you?
Just one time.
What was the plan going forward?
He was supposed to come back in 6 months. So I saw him on February 28th, 2022, if my memory is correct. And so he was supposed to come back in August. And he didn't show, and then I don't know the details of the dates right there, but somehow we were trying to track him or get him to came to light that he had died.
I don't know that I did this earlier. I would have called Dr. Burch an expert in pediatric cardiology. No objections.
Thank you.
In your opinion, is there any reasonable medical possibility? Let me ask you this. Were there any conditions life-threatening for you?
No.
Even though those?
No, sir.
Is there any reasonable medical possibility that they just caused this sudden death?
I guess anything is possible in the world. However, I would say this, I've never seen an issue this small ever creating an issue. I mean, any symptoms or whatever, much less bad, you know.
Thank you, sir. One moment, please. No further questions.
Dr. Burch, these are rare conditions, right?
No, really very common. The coronary fistula is a rare condition.
It's not often I get to talk to a cardiologist, so I'm going to ask some questions that I know is probably for you, stuff you're used to dealing with, but just out of curiosity, you said the PFO. How common is that in children?
Well, actually, it's a normal structure that all babies have. It's the ones that don't close after, like if you were to go into the nursery, hypothetically, and do an echocardiogram on every baby that was born in the first 24 hours, they probably 95, 98% of them still have a baby frame of valve.
Okay. And let's talk about the fistula. How common is
That's
that?
not common. It's like less than 1%.
Okay. And since one is fairly common and one is not very common, the combination of the two, how common is that?
I have no idea. I mean,
Have you ever seen it before?
okay.
Okay. So I assume what you were talking about, Mr. Dean, I'm not sure what words in about 15 or 20 times, I guess you would say. So it's one of
Something to that effect. I mean, you know, like I said, I could go back, I'll probably throw it all up for you, but it's not very common.
it's not a very common thing. Okay.
Although, I will say this is becoming more common because our technology is a lot better when we're looking at the echocardiogram, the flow. And you're seeing more things now that you didn't see previously. That makes sense. And so, you know, so you're seeing them, but still, not necessarily, you know, anything that you would certainly do better unless it's moderate to large in size.
Let's talk about that. So technology, I've been a pediatrician now, I believe, since the 80s, so probably 40 years now, right?
82.
Okay. So I assume technology advancing does help in the diagnosis and treatment of a lot of these disorders, correct?
Yes, sir.
So I guess 40 years ago, these things wouldn't have been diagnosed or as common as they are now, correct?
The moderate to large, you would probably hear them, okay, because it'd be more of a continuous murmur. And if you've got one large enough, then you'll hear it. And I have a patient that has one that you can definitely hear, but hemodynamically it's not significant enough that I've heard her to be considered having it closed. And they did a catheterization, looked at it, came back and said that it wasn't large enough to warrant intervention at this time. So
Well, let's talk about, was it the fistula that you said that could become an issue later on if it didn't close or do what it's supposed to do?
no, I
Or is
didn't.
it PFO?
No, not a PFO.
As you can tell, I don't know much about
That's
this.
okay. That's okay. The PFO typically will either close them, go away, or stay the same size. They typically get bigger. Okay. The coronary fistula, the real small ones, like one had, typically close up all the way and mainly stay the same size. Okay. The moderate to large ones, they can increase in size over time. So that's why you would address those sooner. Now, so someone like when we're a very small one, you would watch him just to make sure that it doesn't progress and, look at the size of his coronary arteries, make sure there's no dilatation and so forth and so on, just to make sure that you're not going to have anything, or try to prevent any issues that way. But unless you're seeing some significant shunning and so forth, these are typically, patients are typically asymptomatic.
And let's talk about the opposite of that. I mean, most of them are asymptomatic, but if something was going wrong and there was shunning, and what would be the signs and symptoms? How would you know?
As I mentioned earlier, particularly in the small like Quentin, he would actually be in what's called congestive heart failure. Okay, and that's a bit of a misnomer when you talk about congestive heart failure, like someone like me, because the heart is still functioning fine. The problem with it is a lot of the blood goes in the coronary artery, goes out the fish to the lung, and then it comes back to the left side of the heart. Does that make sense?
Yeah, it does.
Okay, and so the left side of the heart will begin to dilate. And but also you have what's called pulmonary overcirculation, and that's where the symptoms come from. You can get edema, such as short of breath, easy fatigability. Youngsters that are nursing or bottle feeding or whatever, you're usually tachypnic, breathing fast, and so their major activity obviously is eating. They don't run around. So what happens to them is they can't coordinate sucking, swallowing, and breathing. So they tire, they don't finish the bottle or whatever, and they don't gain weight. So that's one of the parameters you'll look at. In a situation where if there's a question in your mind, is this child doing fine or not, because the heart was big or whatever, you just look at their weight and so forth. And if they're, above 50th percentile, like Quentin was above the 75th percentile, so he wasn't having any issues eating or any of those types of things. So,
Doctor, thank you so much. You've been very informative.
well, thank you for it.
Mr. Dean?
That would be correct.
Thank you. Rob, thank you. You're excused.